Today, the topic of General Club presentation is outcome prediction in older adults with head and neck cancer undergoing chemoradiation. This article was published in JAMA Otolaryngology Head and Neck Surgery on 6th of November 2025. Coming to basics, head and neck squamous cell carcinoma is the sixth most common Head and neck squamous cell carcinoma is the sixth most common cancer worldwide, with approximately 9 lakh new cases and 5 lakh cancer related deaths annually. Depending on the region and population, up to one half of all head and neck squamous cell carcinoma cases are diagnosed in individuals 65 years or older, a group typically classified as older adults. While management of HNSCC typically involves a combination of surgery, radiotherapy, and chemotherapy, depending on disease and patient characteristics, older adults with comorbidity are often unable to tolerate these intensive therapies. Although some may derive survival benefits from aggressive chemoradiation, others may experience treatment-related toxic effects without clinical benefits. To optimize treatment selection, prognostic tools are needed to identify which patient will benefit from and tolerate intensive therapies. Artificial neural networks offer a promising solution as they have shown efficacy in outcome prediction and treatment customization in oncology. ANN can identify pattern and predictive factors in complex datasets, providing critical insight into patient-specific response that traditional predictive method might miss. I will make a brief intro about artificial neural network first, then we will get back into our article. The artificial neural network are computerized systems designed to mimic how the human brain processes information. Just like the brain uses neurons to process data and make decisions, artificial neural network use artificial neuron to analyze data, identify patterns, and make prediction. These networks consist of layers of interconnected neurons that work together to solve complex problems. Key components are input layer. This is where the network receives information. For example, in an image recognition task, the input can be an image. Hidden layers, these layers process the data received from the input layer. The more hidden layer they are, the more complex pattern the network can learn and understand. Each hidden layer transforms the data into more abstract information. Then comes to the output layer. This is where the final decision or prediction is made. As the picture depicts, the first is the input layer. In between there are the hidden layers. They can be they are depicted two, but they can be many. The interconnection between all them, and they have outformed the output layer, which will goes for the prediction or the outcome of the input data. For easier understanding, there is a table for how the artificial neuron versus the biological neurons have been compared. The structure based in structure. As we have biological neuron, dendrite receives signals from other neurons. In input neurons, artificial neurons, input nodes receive data and passes it to the next layer. The cell body, that is soma, that processes the signal in the biological neuron. In this, we say it like hidden layer nodes, process and transform, which process and transforms the data. Then comes the axon, which transmit and proceeds the signals to the other neuron. In this, we have output nodes, which produce the final results after processing. The connection between the biological neuron known as the synapse, that is the link between the neuron that transmits signal. In the artificial neuron, we call it as weights. That these are the connection between the neurons that control the influence of one neuron to the other. The learning mechanism in the biological neuron comes from the synaptic plasticity. That is change in the synaptic strength based on the activity and over time. In artificial neurons, we term it as backpropagation, which by adjusting the weight based on error in prediction to improve the future performance. In the activation in the biological neuron comes when neuron fire when signal are strong enough to record the threshold. But in activation function, map inputs to the output, deciding if the neuron should fire based on the process data. These are the pictorial diagram for the biological neuron and the artificial neuron. In the biological neuron, the input sites are the dendrites, which goes to the cell body or the soma. When it comes to the axon, and from the axon terminal, that the output data comes in the biological form. But in the artificial neurons, we see there are the input codes. In between, there are the interconnection mating with the linear function and causing the activation function to proceed the outcome or the output. Now, coming back to our article, the study objective is to develop and externally validate artificial neural networks for overall survival and progression-free survival in older adults with head and neck squamous cell carcinoma undergoing definitive chemoradiation. The aim of the study was to develop the predictive model using ANN to identify older adults with head and neck squamous cell carcinoma that exhibit a favorable prognosis regarding overall survival and progression-free survival after chemoradiation. By leveraging the Shapley additive explanation values to deepen the understanding of the factor driven the model prediction, thereby advancing personalized medicine for older adults in HNSCC. The study design is it is an international multi-institutional retrospective cohort study. The clinical data from 19 academic centers was collected across Germany, Switzerland, Czech Republic, Cyprus, and US from the senior registry. Study analyzed a specific subset of the senior cohort and international registry, including 1478 older adults which age more than or equal to 65 years, diagnosed with loco-regionally advanced head and neck squamous cell carcinoma, including CT3 and T4, N1 to N3 disease, according to the Union of International Cancer Control and American Joint Committee on Cancer 7th edition TNM classification. Patients with CT1 and T2 and CN0 were not included in this study. This analysis focused exclusively on individuals with loco-regionally advanced HNSCC located in oral cavity, oropharynx, hypopharynx, or larynx, who received definitive radiotherapy with concomitant systemic therapy between January 2005 to December 2019. Approval by the local ethics committee of LMU Munich with the initial database approved by the ethical committee of Freiburg University was taken. Informed consent was waived off given the retrospective nature of the study. The exclusive criteria contains patient with induction or adjuvant chemotherapy, no concurrent systemic treatment, a history of head and neck cancer or previous radiotherapy in head and neck region, or distant metastasis at the start of radiotherapy. Both the standard Carlson comorbidity index and age-adjusted CCI were calculated excluding the primary tumor. Overall survival was measured from the start of radiotherapy to the death, whereas progression-free survival was measured from the start of radiotherapy to death, local or loco-regional progression, or distant metastasis, whichever occurred first. Individuals without event by the end of the study were right-censored at their last follow-up. Minimum follow-up of 2 years or a recorded event by the time of data cutoff. Individuals with overall survival with below 2 years were classified as high risk, while those surviving beyond 2 years were deemed low risk. This 2-year threshold reflects the approximately median overall survival in older adult with HNSCC in previously real-world studies. Oropharyngeal cancer with positive P16 expression were labeled as HPV positive. Patients with non-oropharyngeal cancer and those with oropharyngeal cancer lacking test result were grouped together as HPV negative and unknown. Baseline blood values were collected from 0 to 5 days before initiation of chemoradiation. Training and validation of artificial neural network were performed using the data from 14 of 19 centers of the senior cohort, while independent testing model performance were conducted using previously unseen data from remaining 5 centers of the 19. Artificial neural network optimization. We implemented 2 separate artificial neural networks for prediction of either overall survival and progression-free survival. Both artificial neural network models feature a single fully connected hidden layer with exponentially linear unit activation function, a dropout layer, and output layer with sigmoid activation function. All models were trained using the binary cross entropy loss function and Adam optimizer with early stopping to prevent overfitting. These are the technical terms in the in the AI or in the artificial neural network, binary cross entropy loss function and Adam optimizers. These are the things which are taking for correction of the system, that our software is predicting a right value or not. By this, we used to check binary cross entropy loss function and Adam optimizer. For each endpoint, a separate hyperparameter search was performed based on the training set, which further split into the actual training of 80% and validation of 20%. A total of 192 hyperparameter combinations were investigated. These hyperparameters are the combinations of the input codes which we have given to the data software, from which in the hidden layer they are processed to come out for the output thing. Specifically, we varied the number of neurons in the hidden layer as 10, 15, 25 and 25. The dropout probability is 0, 0.25 and 0.5. The batch size is 32 or 64 and the weight decay is 0 or 0.001 and the optimizer learning rate is 0.0005, 0.00010 and 0.00050 and 0.0010. Statistical analysis involve the calculation of Kaplan-Meier estimates for survival outcome with log-rank tests used to compare difference between the high risk and the low risk group. We also determined the receiver operating characteristic, area under curve, precision recall, and Harley index. The ROC area under curve value evaluates the model ability to distinguish between the classes, providing measure of how well the model can identify true positive across the various threshold setting. The precision recall area under curve value emphasizes precision, that is true positive among the predicted positive and recall true positive among the actual positives. While the no skill value for ROC AOC is always 0.5, the no skill value for the PR AOC depends on class imbalance and is defined as a portion of positive samples relative to all samples, number of the positive samples upon the total number of samples. To compare the artificial neural network with other approaches, we implemented an extreme gradient boosting, that XGBoost model, a tree-based assembly learning method designed to capture non-linear relationship and interaction among input variable for direct overall survival and progression-free survival prediction. We also applied univariate Cox proportional hazard regression for ECOG performance status score, HPV, and N classification. In addition, a multivariate Cox proportional hazard regression model was performed to estimate the relative risk of overall survival PFS using the same set of input variable as for the ANN and XGBoost model. Data were analyzed from December 23 to April 2025. In the results, we see that the patient population of 898 were included in overall survival analysis, from which 738 were taken in the training cohort and 160 were taken in the testing cohort. As such, 945 included in the progression-free survival analysis, from which 770 were in the training cohort and 175 were in the testing cohort. In the overall survival cohort, 665 patients were male and the median age was 71 years. And for the progression-free survival, 696 out of 945 patients were male. The median age was 71 years only. From the overall survival training cohort, that is the 738 patients, most tumor were located in the oropharynx, that were 420, followed by the hypopharynx, 111, and the oral cavity, 91, and larynx, 91. Most patients have ECOG performance status score of 0 to 1, that is 640 of 738, and the median age adjusted CCI Carlson comorbidity index score was 4. Within the cohort of patients with oropharyngeal carcinoma tumor, 200 tumors were HPV positive and 149 were unknown cases. The most common systemic treatment regime was cisplatin, cetuximab, cisplatin plus 5-fluorouracil. The median cumulative cisplatin dose was 180 mg per meter square. Radiotherapy was completed in 666 patient with a median equivalent dose in 2 gray of 70 gray with a sensitivity of 10 gray. This alpha by beta ratio shows the radiation sensitivity of the tissue. If the score is 10, the tissue will be more sensitive and the least score will be 3. Some biological tissues like renal tissue, they show a sensitivity of 2 gray only. They are the least sensitive to the radiation. After a median follow-up of 68 months, the median overall survival was 50 months and the median progression-free survival was 34 months. At the analysis, 428 patient of 738 patient had died. The independent, that was the data shown previously was from the training cohort. Now comes the independent testing cohort. It includes 160 patients from the overall survival analysis and 175 for the progression-free survival analysis from 5 tertiary cancer centers. ECOG performance score was slightly less favorable in this training cohort. That is, with 119 patients, we have seen the score of 1, and in 29 patients, we have seen the score of 2 or greater. Within the cohort of the patient with oropharynx carcinoma, 38 tumor were HPV positive, and 28 patient of oropharynx carcinoma, HPV status was unknown. Cisplatin, mitomycin C, and cetuximab were the most commonly used systemic treatment. The median cumulative cisplatin dose was 200 mg per meter square. Radiotherapy completion was at high at 93%. That was 90% in the training cohort. Here it is the 93.1% with a median equivalent dose of 70 gray. After a median follow-up of 73 months, the median overall survival in testing cohort was 39 months and the median progression-free survival was 25 months. By the time of analysis in this testing cohort, 98 patients have been died. Artificial neural network details. For overall survival, we have found the hidden size of 25, a batch of 32, a weight decay of 0, and dropout rate of 0, resulting in the best validation accuracy. The median prediction score later used as the testing stratification threshold was 0.36. For progression-free survival, we found a hidden size of 25, a batch of 32, but a weight decay of 0.001 and dropout rate of 0.5 to lead the best validation accuracy. That was 0 and 0 in comparison for the overall survival. The median prediction score later used as a testing stratification threshold for progression-free survival was 0.48. The developed artificial neural network exhibit rapid loading and interference time of less than 5 milliseconds. The survival analysis for artificial neural network was during optimization. The model achieved ROC of area under curve of 0.78 and the precision recall of area under curve of 0.67 on the internal trailing and the validation set, substantially outperforming the no scale precision recall area under curve baseline, which was taken as 0.36 for overall survival. In the context of overall survival with the independent testing cohort, 160 patients met the inclusion criteria. The artificial neural network categorized 101 patient as high risk and 59 as the low risk. The Kalpan-Meyer survival analysis demonstrated a significant distinction between the high risk group and the low risk group, which will be depicting in the figure 1 using the artificial neural network. Additionally, the model achieved a ROC under area under curve of 0.68 and precision recall area under curve of 0.57. Compare with the no skill precision recall of area under curve is 0.36. The C index was 0.66. This is the curve for Kalpan-Meyer survival curve of the difference in the overall survival between the low risk and the high risk patient group. The y-axis show the overall survival and the x-axis show the time in the years. As you can see, as the time in the years increases, the overall survival percentage decreases. The 0.2 and 0.4, 0.6, these depict the 20%, 40%, 60% survival rate, overall survival rate. As the time increases in years, the overall survival rate decreases. As in starting, it is showing in the high risk number group, there are 101.
पावर स्विच कौन सा उसमें डाला है एक बार आईटी को भेज दे नहीं तो उसका प्लग बदल दो फिर बाद में
I think power आ रही है उस हाई अच्छा
लो बैटरी
लो बैटरी पावर आ रही है लैपटॉप ऑन
वो दबा
मे बी इसको
बैटरी प्लग है
पावर तो आने तो वो कंप्यूटर
पहले
लेकिन शादी
So in the high risk number, initially the patient were at risk of 101 and in the low risk group, the patient were risk at the 59. But as the year goes on, that the 2 year, 4 year and 6 year, we see the patient were at risk at the 56 and events which were happened eventually changes and increases that, like in the 2 year group we see the high risk individual have the event of 45 and the low risk there are the 13 individuals, but in the 4 it eventually increases to the 64 and 21 respectively. But at the 12 year of gap, we have seen that the 70% of the events were taken place, only one individual have been left with the risk category and 30 patients were being censored. In the low risk category, one patient was at risk, 30%, 30 individual were censored and 28%, 28 individual were haven't had the event before only. The B chart depicts the representative operating characteristic curve in which the baseline was taken as the 0.5, that is the no skill ROC AOC, which you can see the dotted straight line, and the linear exponential curve which is seen above shows that there the good predictability of the software, that it's showing the true positive number of cases in comparison to the no skill ROC UAC, which is taken as the 0.5. in the precision recall curve, we can also again we can see in the y-axis that is the precision, and then the x-axis that the recall true positive rate. The no skill precision recall area under curve was taken as 0.36. The whole data which have been signified by the our software was above the 0.36, which depicts that it have a good predictability towards the outcome. HPV status had the highest impact on the model. Absolute SHAP of 0.48 followed by GFR, ECOG performance status score and nodal classification with mean absolute SHAP value of 0.46, 0.43 and 0.39 respectively. Other features such as C-reactive protein, T classification or tumor site showed lower mean SHAP values and thus less impact on the artificial neural network. Figure 3 displays the individual dependence plot for HPV, EGFR, ECOG performance status score and N classification within the independent testing cohort, where positive SHAP value suggested the high risk and negative value indicated the low risk. In this first A figure shows the bar chart depicting the mean absolute SHAP value for overall survival, offering a ranked visualization of feature importance based on their average impact. They have been assembled according to their status, that which criteria will affect mostly to the SHAP values, that like HPV status, EGFR, then ECOG performance status score, and classification, C-reactive protein, and thereby further list have been gone on which show low effect criteria on the SHAP values, which make predictability of the software less interpretable. B is the SHAP B swarm plot for overall survival, in which we see the color depicts the higher feature value and the horizontal area depicts whether the effect of the value is associated with higher or lower prediction. In this case, we are seeing that the HPV status having the negative value but have a higher feature value depicting in the red, which having a good mean status of the SHAP values. But in the things of sex, creatinine, leukocyte, hemoglobin and age, there is the least mean value which can be considered of the mean SHAP value, which will have a least effect on the overall outcome. So thereby HPV, EGFR and ECOG status were the main criteria which were be making more hyperparameters, or which will be more analyzing the outcome of the software, because they have the more SHAP median values. It is the individual plot for the partial dependence plot for top 4 feature regarding the overall survival. In this we can see that if the in the first chart, that is the HPV status, one is the positive and second is the negative. As earlier shown, that positive SHAP value will indicate a high risk and negative SHAP value will indicate a low risk. So if the HPV status is positive, we eventually know that the patient will be categorized as a low risk patient, and in the HPV status is negative, it will be a high risk category patient. So it is depicted in the chart that SHAP value is 0.2 to 0.4 for the 0, that is the negative HPV status, and for the positive, that is 1, it is in the negative value of 0.08 to 0.1. As if goes on to the further, that is the EGFR at the baseline, we have taken the 70 milligram per 70 ml as the baseline. So the value lesser than 70 have the more positive SHAP value, that is the more higher risk group, and value more than 70, which gives the better clearance and the more chemotherapy effect to the body, have a negative SHAP value. Going further to the ECOG, more the ECOG score, the higher risk group the individual will, the depicted in the chart, the 0 and 1 in the negative SHAP value. So they will be, the patient will have good outcomes, so they were taking the low risk group, and the patient with 2 and 3 have the positive SHAP value, so they will be in the higher risk group. Further, the N classification, the more the number of N, like N0 have the most negative value of 0.01, negative 0.01, which depicts it's a low risk group individual. As the N value increases, the patient have been transformed into the high risk group. In the PFS analysis of independent testing cohort derived from 5 centers, that is N175, the artificial neural network labeled 73 patients as the high risk and 10 patients as the low risk, yielding a significant difference between the both group. The ROC area under curve was 0.64 and the PR area under curve was 0.66, compared with no skill PR of area under curve of 0.53. The C index was 0.62. In the internal training and validation set, the model achieved a ROC area under curve of 0.70 and precision recall area under curve of 0.65, outperforming the non-scale precision recall area under curve baseline of 0.47. This is the chart for Kaplan-Meier survival curve of the difference in the progression-free survival between the low risk and the high risk group, as initially described for the overall survival. This is meant for the progression-free survival. In this also we can see that as the year passes by, the progression-free survival of the individual percentage decreases down. That initially there were the 73 patient in the high risk category and the 102 patient in the low risk category at the year 0 at the starting, but as the year advances, like at the 6th year, we see that only 6 individuals left with the risk and 57 had the event, and 10 patients were censored. And in the low risk category, there are 20 patients with the risk, 18 were censored, and 64 had the event. For as previously described with the numerical values, this is the ROC curve for progression free, in which the no skill ROC area under curve was taken 0.5, but our model have depicted the ROC area under curve was 0.64. That shows it have a good probability of outcomes. For the precision recall curve also, the no skill PR area under curve have the value of 0.53, but we had the PR area under curve value from the software is 0.66. The depiction comes from the chart only. Based on the mean SHAP value of progression-free survival, human papillomavirus status emerged as the most significant influential feature, followed by the age-adjusted CCI score, CRP, and the nodal classification. Variables such as sex, tumor site, ECOG performance status score, smoking history, and hemoglobin level show minimum impact. Again, for the progression-free survival, the plotting have been done for the SHAP additive explanation mean values. Firstly, the log type are being given, but in this you will see that the criteria have been changes. The HPV status is followed by the age-adjusted CCI score. Initially, in the overall survival, that was the EGFR was there, but in this we have the age-adjusted CCI score. Then with the CCI score, then CRP, then N classification. Least comes with the age and leukocytes and hemoglobin grading, which have least eventual effect, or the least mean value, which will affect the overall outcome of the software. Second, B plot shows the B swarm plot for the progression free survival, in which we see the higher feature value, which is depicted in the red, have the more mean SHAP value, which will be from towards the negative. So if the case is positive, if we take the HPV status positive, the patient will be in the negative SHAP value, so it will be a low risk category group. But if the patient comes with the higher, in the case of EGFR, we can see the mean SHAP value will be shifted towards the positive side, so it will be a high risk category group. The comparison of the model performance with the other model was also taken. The prognostic performance of the artificial neural network was compared with other approaches, including an XG-boost model and Cox proportional hazard regression model. Among all tested models, the artificial neural network demonstrated the highest prognostic accuracy. For overall survival, the representative operating characteristic area under curve were 0.68 and for the artificial neural network, and 0.57 for XG-boost model, and 0.65 for the multivariate Cox proportional hazard regression model. For progression-free survival, the corresponding ROC, AOC values were 0.64, 0.62, and 0.60 respectively. Now comes to the discussion part. Based on an international multi-institutional cohort study with the patient data from 19 centers, we developed and trained an ANN for both overall survival and progression-free survival prediction of older adult with HNSCC undergoing definitive radiotherapy with concomitant systemic therapy. Both models effectively stratified older patients with head and neck squamous cell carcinoma in an independent test cohort into high risk and low risk group. The ROC area under curve of 0.68 indicate competent but still improvable performance, particularly giving the class imbalance inherent to the head and neck squamous cell carcinoma. Notably, the artificial neural network demonstrated the rapid loading and interference timing of less than 5 milliseconds. In a related study by the Pan et al. Applied XGBoost model to oropharyngeal cancer, integrating the radiomimics feature from pre-treatment computer tomography scan with clinical data, used the least absolute shrinkage and selection operator sequential floating backwards selection algorithm. Their model achieved ROC AOC and PR AOC score of 0.85 and 0.79 respectively. That is more better than our software that was 0.68. But again, other study of Han et al. Further incorporated the PET scan and the CT and dose distribution data into the deep learning AI model. So they have also achieved an average area under curve of 0.86 for predicting local recurrence after radiotherapy without clinical variables, and 0.89 when clinical variables were included. While these approaches yield higher performance metrics, our approach is streamlined and relies solely on easily available clinical variable. We haven't included any radiographic data or any other data, offering high accessibility and feasibility while extending the analysis beyond the oropharyngeal cancer to the broad head and neck squamous cell carcinoma population. By identifying the key features such as HPV status, kidney function, ECOG performance status score, NN classification, our findings closely align with established clinical knowledge, thereby reinforcing the relevance of these factors for clinicians. Our SHAP analysis revealed that the primary predictor of high risk status for overall survival were the negative HPV status, decreased EGFR values, poor ECOG score, and advanced nodal classification, whereas all other variable extended the small influence on the overall outcome. Significant results for progression-free survival, though with a distinct set of features: negative HPV status, high adjusted CCI score, elevated CRP values, and advanced nodal classification were the most important feature for assigning the patient in the high-risk group. HPV status emerged as a strong predictor of overall survival and progression-free survival, underscoring the role of HPV in treatment response of older adults with oropharyngeal cancers. Pre-treatment EGFR level were emerged as the second most significant predictor of overall survival, with values of 70 milliliter per minute, 1.73 meters square, indicating the improved survival. Both age-adjusted and the non-age-adjusted ECOG performance score and CCI score emerged as a significant predictor of overall survival and progression-free survival, underscoring the critical score of functional status and comorbidity. ECOG performance status score of 0 to 1 were associated with the better survival, and whereas the score of 2 and 3 signaled the higher risk. While tumor-specific factors such as nodal classification exhibit a significant prognostic value of overall survival and progression-free survival, chronological age itself only played a minor role. This underlines the importance of more nuanced assessment of biological age and functional status rather than relying solely on chronological age in clinical decision making. Factors such as comorbidity burden, performance status may better capture a patient treatment tolerance and prognosis and should be prioritized when considering definitive chemoradiation in older adults. The limitation of the study was firstly the retrospective design inherently introduced the potential selection and information bias. Additionally, important clinical values such as standardized geriatric assessment score and nutritional status, blood-based biomarker including albumin and neutrophil to lymphocyte ratio, and biological parameters such as level of tumor infiltrating lymphocytes or tumor hypoxia were not available, potentially limiting the model comprehensiveness. The absence of imaging derived parameters such as gross tumor volume of the primary tumor and involved lymph nodes may further constrain the predictive performance of the artificial neural network. Moreover, tumor staging was conducted according to the UICC and AGC 7th edition, which lacks the improved prognostic discrimination for P16 positive oropharyngeal cancer provided by the 8th edition. Lastly, treatment-related factors such as radiotherapy parameter and the type of systemic therapy, including cisplatin versus cetuximab, were not included in the prognostic model, as our goal was to develop model applicable at the time of initial presentation. Despite these constraints, our work leveraged the extensive senior cohort, which is one of the largest dataset of our older patient with head and neck squamous cell carcinoma receiving curative radiotherapy gathered from the multiple centers across Europe and US, with a robust training set of 770 patients for progression-free survival and 738 patients for overall survival, an independent testing set with the data of 5 centers of 175 and 160 patients respectively were taken. Overall, artificial neural network model demonstrates strong reliability and broader applicability. Conclusion: artificial neural networks successfully stratified older adults with head and neck squamous cell carcinoma into high risk and lower risk group for overall survival and progression-free survival. By incorporating the SHAP values, the model offered transparency and interpretability, marking a significant step forward in personalized radiation oncology. Thank you.